So thank you very much, Benno, and thank you very much to everyone. It's a pleasure to be here again, and also big hello to all those who are following online. So these are the last few presentations, and I'm going to be speaking on health policy and snake bite envenoming. It's mainly to just jog your mind regarding all the issues around policy for addressing snake bite, to understand the complexity that there is inherently in snake bite policy, and therefore what that means for us as researchers to know how to position the work that we do. I always think that as researchers, we should not only be satisfied with being able to produce publications and advance in our career, but to seek ultimate impact from the work that we do. Of course, the distance between our work and the impact it will have will differ depending on the discipline. So if you're doing a lot of very basic science, you may consider yourself distal to the ultimate impact, which is life saved and improved health outcomes. But it is still important that you are concerned about how is my work translated to the next stage, at least the next stage, so that hopefully the next person can also take it to the next stage, and then ultimately we have impact. And ultimately what you want is policy and decision making around addressing snake bite. So snake bite has had its own fair share of ups and downs, and many of you are familiar with this history of snake bite. It was first recognized as an NTD by the WHO in 2009. Then, for some reason, largely political, it was removed from the NTD list, and then obviously there was even less funding for it. And then by some means, and I'll come to that, it was put again as a category A NTD, and then there were some estimates released about how much impact this is having on the lives of people. Again, I personally have problems with some of these estimates, but the fact that I have a problem with the estimates doesn't mean that I have a solution. You see, this is because this is the best that we have. In fact, if you look at the global burden of disease estimates in general, one may argue that the whole global burden of disease estimate is problematic in its own self. But there is no better alternative. So we have to work with what we have, unless somebody is able to provide something better. In fact, a good reflection of how this global burden of disease estimates can be problematic was seen, especially in 2013, when the WHO released their global burden of disease for malaria. And then the IHME in Seattle also released theirs, and there was a big difference. And essentially, there was a big fight played out in the academic journals and in reports regarding all the differences between the estimates. But these were all very astute mathematicians and statisticians. Interestingly, those at the IHME had actually just left WHO to continue their academic careers and so on. So these are very important considerations. And then when you think about it this way, you think about, okay, then how do we end up making policy? I like showing this slide simply because it again reflects sometimes how the powers that be influence the direction of policy. So I was very fortunate to meet Kofi Annan the year before he died in Geneva. And this was barely a few months before snakebite was officially added as an NTD. And when I approached him, of course, to pursue my own agenda, I did not have the opportunity to talk. And he quickly asked me, are you interested in snakebite? And every smart person, of course, when you are asked such a question by such a person, you say, oh, very much so. I have been interested since my childhood. So obviously that's what I said. And then we talked about it. And because he was one of the strong proponents for snakebite, and it was on account of his almost a personal crusade that this was re-included in the list. So this again speaks to how, as scientists, we need to make sure that we are connecting with the relevant stakeholders and powers that be, especially if we want policy issues to be addressed. Sometimes we like to think that, oh, the data speaks for itself, the data speaks for itself. No, the data does not speak for itself. The data is there, but somebody must speak to the data and for the data. And there is no better person to do this than us, the scientists, but we are not trained in this way to communicate, and therefore we rely on the civil society and other organizations to communicate our work, and in that way, hopefully influence policy. Of course, policy must be grounded in science and in fact, not on populism and everybody says it's important and so therefore we make policy on it. Not so, but there is that aspect of it which we miss out on, and sometimes we're too focused on this is the data and it will speak for itself. It is not so. So this is just to show you how normally the data should speak for itself, but it doesn't. You can see the distribution of medically important snakes globally. Now the question is, even for these estimates, how reliable are they? You can see some countries in bright red and others right next to it of a completely different color. What this tells you, if anything, is that there is a strong difference in availability and quality of data, even between countries that share borders. If you look at the latest snakebite mortality estimates for Africa, you would see not even mortality, just incidence estimates for Africa. The most recent, I think, from 2019, 2023, actually, in May, this was released by the WHO. You would see that Ghana has one of the highest in West Africa, I think second only to Burkina Faso. Now, the question is this really the case? Your answer is as good as mine, perhaps not, but it's only a function of how much data is being collected and is available. Nonetheless, it is still very clear that there is a problem. Now, if you look at the global age standardized mortality rate also for snakebite, you would realize that since 1990, especially for males and females for that matter, it has reduced considerably. It suggests that progress is being made, actually a 36% decline, but this decline is not enough for us to meet the 2030 targets. Nonetheless, the question remains, what is influencing this decline? If you ask me, and looking just to take a cursory look at the numbers, I don't think it's a real decline. It's kind of an artificial decline, but most likely as a result of overestimation of the incidence in the 1990s as opposed to the year 2020. It doesn't mean that the incidence is not high, but more likely that the 2020 estimates are more reliable evidence of what the burden is. So this should tell you that even comparing year on year, you have great difficulty really understanding what is taking place. And this begs for policy on a standardized approach to measuring the burden of snakebite. So we have our roadmap or our guide for addressing snakebite envenoming, as you are all familiar with. And the 4 strategic objectives, which we know are empowering and engaging communities, effective and safe treatments, and health system strengthening, and increasing partnerships and resources. And I'll be speaking to each of these in the light of policy. Quite clearly, you would see that there is need for policy considerations for each of these, because these don't happen organically. There needs to be policy that allows actions to be taken along each of these 4 strategic objectives. Now, if you ask yourself, in endemic countries, how many countries have a distinct snakebite policy? If you look very carefully, in many countries, NTD policies or plans, you would barely see a line or 2 addressing snakebite. This is largely due to the absence of reliable data, and countries are very reluctant to make policy when they do not have strong data to back it, or are not in a position to collect data which will show any changes in progress or impact of any policy decisions that are made. I'll speak to these one by one, but also what you see here is these same strategic objectives in the roadmap, and you can see them over here. Now, what this shows clearly is how policy really is the bedrock of achieving this 50% reduction in death and in mortality and morbidity from snakebite by 2030. It's really, at the end of the day, policy that you want. And if you look carefully also, let me see if I can play around with this, if it's working. It's not working the way I thought it would. Never mind. But if you look carefully here, you would see that there is this first pilot phase, which is supposed to end by 2020 and so on and so forth. But again, here COVID happened and then everything has gotten disrupted. So we are already clearly behind time. If you ask me for my personal opinion, I think there is need for maybe a small revision to this 2030 plan, because we did not anticipate COVID and it's thrown everything out of gear. It's already abundantly clear that we may not be able to meet these 2030 targets at the rate at which we're going. So speaking to empowering and engaging communities, you can see a very recent paper by the eminent snakebite researcher, Maoli Aglanu, over here. And he published something on community members and healthcare workers' priorities for the control and prevention of snakebite envenoming in Ghana. Again, this speaking to how, aside just the policy, the stakeholders or the actors involved are very important in being able to elicit what the priorities are. It's exactly this kind of work that ministries of health and other stakeholders can fall on to build policy. And this reflects the importance of the work that we do as researchers, because at the end of the day, the policymakers, even if they may not overtly engage with us for various reasons as scientists, they will engage with our work. And it's very interesting to see in Ghana's NTD policy document how for snakebite, they actually quoted the figure that we worked on and which was put in actually a newspaper. And this is the figure that they've quoted, but they never approached us directly for any estimates or any information. But this should tell you how it's work like this that actually does influence policy, especially when it's published in a highly visible manner. But then ultimately, it boils down to community empowerment and around the field of education, communication, training, and facilitation. And policies around including community engagement when it comes to snake bites are yet to be properly formulated for many endemic countries. We've had a very top-down approach to snake bite prevention and control in many endemic countries, and the engagement with communities is often lacking. And I'll explain why this kind of policy is lacking. It's because of the potential trade-offs of some of the actions that would reduce the risk of snakebite, and these make for very important, even deeper policy considerations. And I'll speak to that very shortly. Then the ensuring safe and effective treatments, again, the access to antivenoms, and making sure that they're effective enough, that they are produced at the appropriate rate, and so on. Investment in production. Many endemic countries are eager to look into or actually have policy of producing their own anti-snake venoms. In Ghana, for example, this is one big thing on the government's agenda, very interestingly. And by the end of this year, there will be a homegrown pharmaceutical company that will be doing fill and finish of anti-snake venom right here in Ghana. I met this right in Ghana, not here, in Ghana. I met the CEO of this company, and he's eager to engage in some trials of their products. But again, in as much as we believe and try to promote local production and so on and so forth, questions always arise around the quality of these antivenoms and how effective they will be. And there's a lot of politics around this, the question of economies of scale, whether it is at all cost effective to do this. These are all very important questions. Now, the policy in Ghana and in many endemic countries has been around the free provision of anti-snake venom. But the fact that the policy exists does not necessarily mean that it translates into real access, because what we see more often than not is that the antivenoms that are procured are perhaps of substandard quality, not perhaps they are of substandard quality, and then the distribution of this is not adequate per the regions of the country that need it the most. And then very sadly, sometimes you would find some of these otherwise free antivenoms in the private for-profit sector, because that some way, somehow, they end up being sold. And so there is hoarding of some of these for various reasons. And ultimately, it is the patients that suffer. Just to take a small digression, it is very, very painful to visit a facility to see 2-3 people bitten by snakes, and there is no antivenom, and you know that when you come back in 2 or 3 days, most likely these people will be dead. I've had that experience personally, and it's a very disturbing situation to be in. I remember I visited at the home of somebody who had been bitten by a cobra a couple of days prior, and you could see the tendons showing and the necrotic tissue around the leg. And we gave the person some money, go to the hospital, but in as much as we're doing that, we knew that perhaps this limb is not going to survive. But all this is really simple policy that could address some of these. And it's very important that we bring in some of these personal stories just so that we can be more proximal to the realities on the ground. And what I spoke about really speaks to the issue of health system strengthening. Is there a deliberate effort specifically focused on snakebite around health system strengthening? Or let me put it this way, is there a health system strengthening agenda or policy that directly addresses snakebite? And you realize from the snakebite roadmap that strengthening health systems is one of the key objectives over here, recognizing that without strengthening health systems, you most likely may have some period of progress if you have a vertical program addressing access to antivenoms and so on and so forth. But sustainability can be a huge challenge. So if you really want to achieve success with snakebite envenoming prevention, you really need to use a health system strengthening approach. And the picture that you see over here simply shows how a One Health approach is really what is most recommended towards this. Then there's the increased partnership and coordination of resources. I've spoken to this in my opening, the data, then the advocacy for the data, and then collaborations along various lines. Now, the reason why collaboration is so important is that there's a huge variation in the kinds of snakes that we have in various countries and the impacts that these snakes have, and therefore the implications for the kind of antivenoms that are needed. Currently, many endemic countries, polyvalent anti-snake is what is recommended simply because of our inability to be sure enough about which snakes might have bitten somebody. But there is some evidence that if we have some degree of confidence in what snakes may have bitten an individual, then a monovalent approach, albeit very carefully targeted, would be able to result in better outcomes of snake bite. What this also means is that diagnostics become very critical in being able to have point-of-care diagnostics, which may quickly tell us what snake might have bitten the individual and therefore can advise us to whether we should give a polyvalent or a monovalent. All these can only come through intense collaboration, right from collaboration with the naturalists or those who deal with the environment and the wildlife, through to those who are dealing with the molecular kind of work, and then those who are dealing with the clinical kind of work. It will be practically impossible to achieve enough success in snakebite without collaboration across the board. Now, if you understand how the research on snake venoms has been progressing globally, you realize that a lot of it involves the catching of snakes in many endemic countries, especially in Africa, the shipping of these snakes to labs outside of these countries, and then the exploration of these venoms, and then the development of antivenoms, and so on and so forth. What you really need is collaboration that allows as much work as possible to be conducted in country for some of these. And I know George, where's George? Yeah, George is here. Good. Yeah, George has built a really wonderful snakebite research center in Africa. If you ask me for policy direction around snakebite research in Africa, my recommendation will be very clear, that if we're able to identify 1, 2, maybe 3 maximum centers of excellence and focus attention on these to be able to develop capacity for snakebite research right from the molecular level through to the clinical and implementation level, we will make huge strides. Because a lot of what people like George is doing in Kenya can easily be applied to Ghana. If we could catch snakes in Ghana and take them to Kenya and continue work there, why do we need to replicate exactly the same thing that George is doing in Kenya, in Ghana, for example? Of course, there's always a national thing there, but ultimately, if we want to move very fast and move decisively and more comprehensively in snakebite, this collaboration between countries is absolutely important, absolutely important. I cannot overemphasize this. Also, around policy, I spoke about these trade-offs that come along with, a snakebite policy, especially around the prevention. Now, if you are looking at prevention of bites and policy around prevention of bites, some of it would involve reduction of contact between humans and the animals. Reduction of contact also comes along with a trade-off of perhaps reduced farm output or reduction in livelihood. So how do you address some of these trade-offs of reduced contact between snakes and human beings? Ultimately, contact cannot be completely eliminated, but once there is subsistence farming, contact will be present. Of course, one may think about the provision of boots and other preventive gear, and getting people to use them is another step forward. But these are very, very huge challenges which require a lot of research. Otherwise, you provide the boots, you provide the gloves, and do everything, and they will not be used. And we've seen these in several instances, especially in the malaria world. People like to talk about back in the day when nets were being provided as a prevention for mosquito bites. And people took the nets, and in some communities, they used them to fish because it was more productive than hanging it and sleeping under it. Again, it just reflects how implementation research is very critical in developing appropriate policy. And then also the reducing of the poor outcomes from snakebite, loss of limbs, mortality, PTSD. What is the policy around this? Hardly any policy around reducing the sequelae of snakebite, not to speak of even the mental health outcomes. And I know Leslie has done some work on this, looking at the mental health outcomes for snakebite. And I remember when we were on the field, we did speak to a number of people who obviously were suffering from some kind of PTSD secondary to their experience with snakebite. And then this translates into just poor quality of life, reduced economic output, and so on and so forth. To what degree our psychologists, psychiatrists trained in this and also able to address this at a local level. Then the policy around antivenom supply. I've spoken to this already, so I'll not spend too much time with it. If you look at the list of WHO pre-qualified antivenoms, it's very limited. But WHO can only operate within a certain space, which is making sure that antivenoms reach a certain standard before they would recommend them. So the vast majority of antivenoms which are purchased by endemic countries will not be in this WHO pre-qualified lists. So what this means, obviously, is that the cost of these antivenoms that are pre-qualified would have to be reduced. There would have to be mechanisms for purchasing and supply available to these countries. Just like back in the day for malaria, there was the Affordable Medicines Facility for malaria, which had this green leaf thing on the box. It was present almost across the entire continent, from Kenya and East Africa through even to Ghana and West Africa. It was the same kind of WHO pre-qualified anti-malarial subsidized ex-factory price, and made a huge difference in access to the drugs and ultimately outcomes. If a similar subsidy, broad subsidy, can be explored and a supply mechanism, either via the Global Fund or any other mechanism, which malaria, HIV, AIDS, and TB have benefited from, can be instituted, I think to make a huge difference, a really huge difference in snakebite reduction. And if there can be some global policy in this direction, will make a difference. And also we'll be able to measure fairly accurately the impact of this. I remember I was part of the independent evaluation of this global subsidy on antimalarials, and the work really was very straightforward, very clear, quasi-experimental design, and you could see the difference between those countries that engaged with the global subsidy and those that didn't. And the same can be done for snakebite, and it will be even much easier to measure the difference, because snakebite is something that's very difficult to hide, and its impact is perhaps more overt than even malaria. I need to move a bit faster now, so I'll just quickly go through these. But this is just, again, more on the access to antivenoms and the whole questions around making these properly available. It sounds like a very simple thing to solve, but all these years, unfortunately, we are yet to get there. But there are some clear policy recommendations guiding the production of anti-snake venom. And at least that's a very positive thing. The WHO does have this policy, and it's available for countries. The interesting thing is that while all these exist, many countries simply are not aware of this. If you speak to country NTD program managers about snakebite, you'd be surprised about how little they know about snakebite. It's often about the preventive chemotherapy NTDs, the big five, as I call them. And this is because there's a lot of funding for these, but hardly is there significant funding for snakebite, and so the interest of program managers in this is relatively low. And I remember last year when I was presenting, I showed how in Guinea, the NTD manager was asking for help regarding snakebite, and then I was able to put them through directly to the snakebite unit at WHO in Geneva. So these are just some of the recommendations. I need not go through them, but maybe what I want to point out is here. National health authorities should organize independent preclinical efficacy testing prior to importation of any antivenom to avoid national distribution of dangerously ineffective products. How many are doing these? George, is this being done in Kenya, for example? Just started. We're not doing it in Ghana. I don't know who else is doing it. I don't think there's any other country doing this.
Bangladesh is working on it.
Sorry?
Bangladesh is working on it.
Working on it.
Almost there.
Almost there, you see. So you see how long it's taken for this to actually be pursued, and how many are even pursuing it at all. But it's just to tell you that we have some ways to go. I want to conclude by re-emphasizing the need for us as scientists to engage with not-for-profit organizations, because these, so not-for-profit, I didn't mean not-for-profit, I mean civil society organizations. Society organizations, because these are the most likely vehicles for amplifying the work that we do as scientists. And these organizations are often very skilled and knowledgeable in highlighting the relevance of snakebite. However, I have to caution that it's not very easy as a scientist working with some of these organizations. I have personally had occasion in engaging with some of these organizations, not the ones listed here, to be fair, where sometimes they quote unquote want to hijack the work because of the visibility it gives them and the funding it brings to them. I remember there was one, I'll not mention, very prominent organization that wanted to come to Ghana and engage with the health authorities on snakebite and go up to WA and do some documentaries and so on and so forth. And they
asked for my advice on the telecon. I gave them quite a bit of advice. I said, however, I would like to engage further, more officially with you, with my group, so that we can do this together. And they said, yes, you will hear back from us. And that was the last I heard back from them. I don't know whether they did what they wanted to do or not, but it was clear that they lacked the technical expertise in certain areas. But for some reason, they wanted to go it alone. But these are the challenges, but we still need to collaborate with some of these and work with some of these if we want to have more success in the impact of some of our work. Okay, so these are just some of the summary of the points that I had made, which are on the slides. I'm sure they will be shared, so I'll not spend too much time with them. But I'm just concluding on this last issue, which is the issue of data, which I started with and which I want to end with. For policy, good policy can only come out of good data. And with Snakebite, you'd realize that we are struggling to have good data to be able to make good decisions. We're struggling to pull the dial up. And the evidence for me is seen in the estimates. If you look at the huge difference between countries that are very similar in terms of mortality from snakebite, in terms of incidence of snakebite, then you begin to question, is this data really reliable enough? And it goes down to just the basic things of just collecting simple, clear data. Otherwise, you cannot make good decisions. Poor data will lead to poor decisions or poor outcomes of decisions that are made, and ultimately what you have is trouble. So my take home is that to really be successful in public health policy for snakebite, the emphasis for now must be on better data. And with that, thank you.
Thank you very much, John. Are there any